Good afternoon, and welcome to this European Heart Journal Dialogue. I'm Carlo Patrono. I'm a deputy editor of the journal for the weekly Journal Scan section. And on behalf of Professor Filippo Crea, who is the editor-in-chief of the European Heart Journal, and the associate editors who make a wonderful team of Weekly Journal Scan, I would like to welcome our distinguished guests, Timothy Garvey and Tricia Tan. Timothy Garvey is professor of medicine at University of Alabama at Birmingham in the US, and Tricia Tan is professor of metabolic medicine and endocrinology at Imperial College in London. And the coordinator, the chair of this interesting dialogue will be Professor Giovanna Liuzzo, who is a professor of cardiology at the Catholic University in Rome. And so, Giovanna, I would ask you to please introduce the topic of this dialogue and the first guest.
Thank you very much, Carlo. It is a great pleasure to welcome our audience and our guests to this dialogue on multi-agonist strategies targeting obesity to reduce cardiovascular risk, and in particular about the REDEFINE-1 trial. So we'll discuss the REDEFINE-1 trial published recently in the New England Journal of Medicine. The first author is Professor Timothy Garvey. And he will review with us the trial design, the key findings, and their implication for clinical practice. And then together with Professor Tricia Tan, the discussion will explore the biological rationale for the dual GLP-1 and amylin agonism and compare this approach with other dual agonists that are already in the market, like tirzepatide, and other new molecules like amycretin, or even others if we like to do this. And then a particular part of the dialogue will go on the expectation that we have regarding the cardiovascular outcome of this dual agonism. First of all, it is my great pleasure to introduce deep more in detail Professor Garvey. You said already that Professor Garvey is a professor of medicine in the Department of Nutrition Science at the University of Alabama at Birmingham, where he also serves as director and PI of the NIH-funded Diabetes Research Center. But this is nothing in comparison to what Timothy has done regarding his pivotal contribution to understand the metabolic and molecular basis of insulin resistance, type 2 diabetes, obesity. He has been a leading voice in defining obesity as adiposity-based chronic disease and advancing clinical guidelines for obesity, diabetes, NASH, and bariatric surgery. He developed the cardiometabolic disease staging system to guide prevention strategies for type 2 diabetes and cardiovascular disease, and has shaped the integration of new obesity therapies, and this the topic of this dialogue, into a complication-centric model of care. Now, Timothy, the first question is from myself to you, and of course has to do with the REDEFINE trial. So the REDEFINE-1 and the REDEFINE-2 trials have generated a lot of interest by demonstrating the potential of this new dual agonism, cagrilintide and semaglutide, fixed combination. Could you for us outline the strengths of these studies and, for example, the design, the active comparators into the trial, and discuss also the main limitation that as clinicians we should have in mind when we try to apply all these findings into our daily practice. So this is my first question for you.
Well, thank you, Giovanna. That's a big question. I will start with REDEFINE 1, which was a phase 3 clinical trial that assessed safety and efficacy of CagriSema, this combination dual agonism for the GLP-1 receptor and the amylin receptor. Both of these are peptides, long-acting peptides injected subcutaneously. And the study had four randomization arms. There was placebo, there was cagrilintide, this long-acting amylin analog by itself as a monoagonist. There was semaglutide, our GLP-1 receptor agonist that we're more familiar with. And then the combination, what we call CagriSema, is a 72-week study. And the efficacy outcomes for weight loss, I think, were quite remarkable. The average weight loss was about 22.7%. And the categorical weight loss, about over 40%, lost 25% or more of their body weight. So this places this among the most efficacious medicines that we have or hope to have. And this was associated with a lot of metabolic, cardiometabolic benefits as well. Increase in insulin sensitivity, decreases improvement in glycemia, prevention, reverting prediabetes to normal glycemia. The blood pressure response, I think, was very remarkable. Close to 11 millimeters of mercury decreased in systolic and over 5 millimeters of mercury decreased in diastolic, which is a little bit more blood pressure lowering than I'm used to seeing in these obesity medicine clinical trials. And of course, lipid improvements as well. So overall, a very nice result for patients with obesity. REDEFINE 2 was a companion study in patients with diabetes and obesity. You know, whenever with any intervention, there's always about 30% less weight loss in patients that have diabetes and obesity than obesity alone. And the average weight loss there was between 13 and 14%. But hemoglobin A1C targets were met over about 4 out of 5 met the less than 6.5% hemoglobin A1C level with a minimum of hypoglycemia. So this is a remarkable result in diabetes, and it teaches me anyway that the best medicines for diabetes are often the best medicines for obesity. So I hope that's just a short summary, Giovanna. I hope that's helpful.
Thank you very much, Timothy. I have another question to you, but first I would like to say to our audience, please put your question into the chat because Professor Patrono, not me, because I cannot read the chat, I'm sorry, will take care of bring your question to our guests. The other question is about something that we have just said a few minutes ago. There was an unbelievable weight loss with the CagriSema compared with placebo, but also compared with the semaglutide alone. And it's for sure that we now are used to understand and even to prescribe semaglutide. So my question is, with patient population, do you think, do you envision could benefit most from this dual agonism approach?
Yeah, I think, you know, with the principles of complication-centric care, the real targets of our therapy is to improve the complications and related diseases associated with obesity, because that's what impairs quality of life and confers morbidity and mortality. So the idea there is to get sufficient weight loss to prevent or treat those complications. So when we need a kind of a higher level of weight loss, you know, greater than 20%, that's when we would use a medication like CagriSema. And you're right, the weight in a head-to-head comparison in REDEFINE 1, the weight loss with CagriSema was greater than any of the monoagonists, semaglutide or cagrilintide. So I think that's what we just have to individualize therapy, and to achieve the clinical outcomes that we want in each patient.
Thank you. So if there are no questions from the audience right now, I will ask Carlo to take the stage and ask more questions. I have more questions for both of you, but it's the turn of Carlo to ask questions.
Well, first, let me introduce properly Tricia Tan. Professor Tricia Tan is chair in metabolic medicine and endocrinology and a consultant in diabetes endocrinology and metabolic medicine at Imperial College London. She has over 20 years experience in gut hormone research and physiological studies into the impact of gut hormones on weight and type 2 diabetes mellitus. She has participated and completed several phase 1 trials on the gut hormone analogs, which are being developed for the treatment of obesity, like the one we are discussing today. She's also the director of the SAS Gut Hormone Service, and her clinical interests are wide-ranging across all spheres of diabetes, endocrinology, and metabolic medicine. So, Tricia, let me pick your brain and ask a question about the biological rationale of this dual agonism, targeting GLP-1 receptors and amylin receptors. So when combining the two, we introduce a novel mechanistic strategy for obesity treatment. And could you explain how these two pathways interact in regulating appetite, gastric emptying, and glucagon suppression, and why this combination may produce greater and perhaps more sustained effects than GLP-1 receptor agonism alone?
Thanks, Carlos, for the introduction. Whoops, my computer's, I'll turn that beeping off. Well, I think this is a really exciting time for multi-agonist treatment and treatment of obesity and diabetes. A lot of these multi-agonist currently approaches have been using GLP-1 as the backbone. So CagriSema is just one of many strategies. As you mentioned, there's also tirzepatide, which is a GIP and GLP-1. We've also got the glucagon and GLP-1 strategy, and also triple agonist. Now, this concept does stem from some of the physiological responses that we see after bariatric surgery, as an example. So after bariatric surgery, you get this instant improvement in glycemia, even before weight loss occurs. Postprandially, you see that the gut hormone levels released from the gut is 2 times, 4 times higher than what you would see in someone who hasn't had bariatric surgery. So I think some of the early concepts certainly has sort of arisen from the fact that we actually see this naturally in a weight loss and metabolic intervention that leads to sustained long-term outcomes. Now, in terms of all these combinations, well, I think it's interesting because targeting appetite is not a single receptor. And the right approach is, I think where we've gone wrong in the past is that we've tried to find a single agent to target obesity. And this multi-agonist approach is exciting because you're not just going for one receptor, you're going for multiple receptors. But I would say that all the pharma companies have rushed forward with developing multi-agonists, but we're now ended up in a conundrum of which multi-agonists to choose. Okay, we've got really good data on GLP-1, long-term cardiovascular outcomes, and I would say that is a strategy approach that we feel very comfortable with. But then now we're stuck with, well, what does the cagrilintide bring? Okay, but what we've shown, I really like this redefined one study design because, there was an arm where you had the placebo, you had the single agents, you had semaglutide, you had cagrilintide, and then you showed the combination. And the combination, there was more AEs, but flexible dosing. That's reflective of real world. So, and I suppose I might ask Timothy this, in terms of some of the benefits that we're seeing now in terms of blood pressure, do we think this is more weight loss related? Because certainly, how amylin works, to me, I suppose the main biological effect here is appetite suppression. But there is also lots of discussion in the field as to, does it have an anti-inflammatory effect? Does it have an energy expenditure effect? So there's some animal data that have shown that with weight loss, you're maintaining the energy expenditure. And what is the mechanism? So there's still a lot of basic research that we actually still need to explore to understand the long-term effects. But certainly, it's open more questions, basically. I would say the multi-agonist strategy. And it's the same with tirzepatide, is the benefits we're seeing, the combination hormone, or is it because of the biased GLP-1 activity? So it's difficult to say, but I think at least we have a choice. We've got treatment approaches that can target weight loss that is paralleling bariatric surgery, but we still have a lot of unanswered questions. What do we do long term? Do we keep the patients on these drugs indefinitely, lower doses? Do we use the multi-agonist to get that big weight loss and then move to just say a single GLP-1 agent? It's unknown, but it's also exciting. I don't know if, Carlos, I've answered your question in terms of mechanism.
But I'll come back to that. But let's hear what Timothy has to say about your points.
Yeah, well, Dr. Tan has really outlined all of the research we need to do and the unanswered questions that are intriguing and exciting. I would say what REDEFINE 1 taught me something that I think is important clinically. There was a very flexible dosing schedule built into the protocol. So study sites could slow down the escalation, they could decrease the dose, they could maintain patients on submaximal doses throughout the study. And when we went to look at the data, it was evident that patients that finished the study on lower doses, on submaximal doses, lost even more weight than patients that finished on maximal doses. And what does that mean? To me, it highlights the heterogeneity of obesity and the responsiveness to these very powerful anorexigenic drugs. So there's some patients that respond very, very well to submaximal doses and do just fine. And I think this has implications for real world care. And if you look in patients, a lot of patients are on submaximal doses that are being treated. So, and I think this is true of all the obesity medicines, but it just becomes more manifest with these very powerful agents. So that's one thing. And what does cagrilintide bring? Well, it does activate. It does interact with receptors and feeding centers in the brain, both the hypothalamus and the brainstem area postrema. It tends to activate different cell types than GLP-1, which could be a basis for its additive effect with the semaglutide in terms of producing more weight loss. I don't think we know much about amylin and blood pressure regulation. I mean, there is some data on there that both would indicate it could increase blood pressure or decrease blood pressure. But in REDEFINE 1, it did lower blood pressure as a monotherapy. So, and it was additive to semaglutide. So, I think this highlights Dr. Tan's statement about multi-agonists. When we attack different pathways for a complex disease like this, we're likely to have more efficacy.
There is a question in the chat that I can read now that is also in line with a second question that I would like to ask to Timothy, but also to Tricia, to both of you. The question in the chat is about patient selection. and what type of patient will benefit most about the combination therapy, and comes with my question for you. As cardiologist, I was quite impressed by the SELECT trial and also by the STEP-HF, PEF, STEP-HF-DM. That means the trials that in people with obesity, even without diabetes, there was an improvement in the cardiovascular outcome in the SELECT and in the outcome of HF-PEF, that for cardiologists know is something that is very difficult for us to treat. There was only the SGLT2 inhibitors until semaglutide efficacy in this population. So it was really amazing to see the improvement in the outcome. My question is exactly what type of patient will benefit of CagriSema, and what you are expecting regarding the cardiovascular outcome from combination like this or even other combination. And do you think there is only weight loss? It's for both of us, of you.
Well, I guess I'll start there, Tricia, unless you want to, but
Please go ahead.
Yeah, the SELECT trial was a remarkable study and with patients without diabetes and demonstrated cardioprotection. It also demonstrated better outcomes for congestive heart failure, both HFpEF and HFrEF for that matter. And as well as other things, slowing the rate of renal decline in patients with chronic kidney disease. So, I look at these medicines as cardiometabolic disease medicines because they not only prevent progression of cardiometabolic disease, prediabetes going to diabetes, or reduce liver fat and hepatic steatosis. But once you develop the end-stage manifestations of cardiometabolic disease, it treats multiple of those. It's cardioprotective. They treat congestive heart failure, diabetes, improve liver histology and MASH, and slow the rate of renal decline. So it's a cardiometabolic disease medicine, and that's the GLP-1 component. So when we add these other dual agonists and triple agonists, we presume that we retain the GLP-1 benefit, but that's a presumption. I think it's a good presumption, but it's a presumption nevertheless. But I think that's something we have to keep in mind. Tricia, do you want to add to that?
No, I think this actually shows that, whilst these drugs have now, translated to routine clinical use, there remains a lot of interesting questions, and that we must not neglect the fact that we still need to actually try and answer some of the basic questions. So I think what's really interesting in the GLP-1 field, plus all the other incretin hormones, is that what we're now interested in is this weight loss independent mechanisms that we are observing. Okay, and the SELECT trial, I think, is a really good example, because you start to see the separation of curve in terms of the CVOT, the MACE outcomes, even before patients achieve that significant weight loss. So we're now starting to think a little bit about the weight loss independent benefits plus the weight loss benefits, and it's exciting. And I think these dual and triple agonists, we need to start thinking a little bit about, well, we've opened another can of worms. We need to now know what the long-term effects are of all these other drugs are. Because giving an example of tirzepatide, which has GIP as the other incretin hormone, there's also the GIP antagonist, maritide, that has also been shown to work. So what is GIP doing and what's the GIP antagonist doing? Why do they both lead to weight loss? We haven't actually answered that question.
No, we haven't. In terms of the weight loss independent mechanisms, it really appeared to be operative with cardioprotection in the SELECT trial. But I'd hasten to rule out the benefits of weight loss.
Yes.
With these cardiovascular outcome trials, demonstrate decreases in the hazard ratio of maybe 15 to 20%. Even statins, maybe 30%. So we have a lot of residual risk there. And there's meta-analysis with bariatric surgery showing you can reduce hazard ratios by 50% in terms of cardiovascular death and myocardial infarction for that matter. So, the sub-analysis of the Look Ahead study, a lifestyle intervention in diabetes, a sub-analysis looking at those that lost more than 10% of their weight, also demonstrated about a 20% reduction in the hazard ratio for MACE. So I think there's weight loss dependent effects as well
Yes.
that we can't neglect.
Giovanna, if I may dwell into the contribution of the two components, let me ask Timothy. So you saw that both components were active on their own, with Cagri reducing body weight by 15%, by 12%, semaglutide by 15%. And so the effect of the combination of the two was less than additive, suggesting some degree of redundancy in the agonism of GLP-1 versus the agonism of amylin. Do you have any signal from more sophisticated analysis than you published in the New England Journal of Medicine, telling us what is the specific contribution of each of the two components to the overall body weight reduction? For example, is there reduced inter-individual variability when you compare the combination versus the two single agents, or even to semaglutide, for which we have much more extensive data? And do you see any clinical readout that is specific for amylin agonism as compared to GLP-1 agonism?
Carlo, I don't think we really understand biochemically how amylin and semaglutide work together to create improved efficacy. You're right. It's additive, but not. It's less than additive.
Yeah.
And I mentioned that these two peptides bind to activate different cell types in the hypothalamus and brainstem, but they also overlap in terms of cell types they activate. So that could explain the less than additive efficacy for weight loss. But to get to the last question you asked, whenever we have a GLP-1, we're going to have nausea, vomiting, diarrhea, and constipation. In the clinic, we can mitigate that by slower rate of progression and using submaximal doses when we have met our clinical goals. But there's still those side effects. And what I think but a lot of times our patients don't need 20%, 25, 30% weight loss. They do very well with 15% weight loss or so, and don't need this extra weight loss. It's even not healthy in some patients. And what we're missing in clinical medicine, I believe, is a medicine that gives us modest weight loss in the area of 15%, that's well tolerated, and is also, accessible and affordable. We don't have that right now. I'm hoping cagrilintide can fill some of that void, because the one difference is it's better tolerated from a GI symptomatology perspective, okay? The rates of nausea were 1/3 to 1/2, what's observed in GLP-1, and vomiting was very low, essentially equal to placebo. So I think it's better tolerated medicine. And now in drug development, I think the field of battle is not efficacy, because we have we will have more drugs producing over 20% weight loss. It's tolerability. So we'll see how things go.
I think, Tim, coming back to your point about the tolerability, we certainly, I for the last 20 years, I've infused these hormones into patients, and certainly we always observe there's some patients who are more sensitive than others in terms of the hormone response, and it's very much recognized. But the other interesting thing is where you're wanting to know the additive or the synergistic effect, which one's which. What we have shown in the past is that when you give even sub-anorectic dose of combination hormones, you do see this 1 + 1 could be even more than 2. It ends up being 3. So how these hormones actually work together is very, very interesting. We don't have all the answers, but we know certainly that there's synergistic effects.
So Tricia, what you're saying, correct me if I'm wrong, is if we use submaximal doses of semaglutide and cagrilintide, we may see a synergistic effect or an additive effect.
We may. We've not done that study. I've looked at that with other hormones, GLP-1, PYY.
That would be interesting because
Yeah.
then you could use you'd have an effective medicine with a GLP-1 component and perhaps have less GI side effects.
Yeah.
And hopefully retain some of the cardiovascular benefits of
That's
the
right.
GLP-1 component. So I hope drug development goes in that direction, actually.
Yeah.
We'll
And
see.
I hope we don't stop asking, the questions about, mechanisms, the basic science behind here. There's so many unanswered questions and the long-term effect. But I come back to the point that, the fact that you demonstrated flexible dosing, and the fact that you still see the benefits at lower doses and good response does highlight that we're treating a very heterogeneous population, and our treatment approach to obesity and all other comorbidities needs to be catered to the patient itself. It's not one size fits all. And I think we're going to be faced with the challenge when, we're sitting there in clinic, we've got a patient with a BMI of over 40 with cardiovascular disease, and perhaps one other comorbidity. Which drug do you choose first? How do you counsel them about what your plans are for them in terms of treatment long term? It's and I think the long-term outcome data is going to dictate how we select these drugs.
I think you've just explained precisely the principles of complication-centric care.
Yeah.
I think I've been since the ACE guidelines in 2016. I've been an advocate of complication-centric approach to care of these patients. I just go back to cagrilintide. The GLP-1, it's mainly the data is mostly secondary prevention of cardiovascular of MACE outcomes. And so what if we're good, and there's an active development program for cagrilintide as a monotherapy. But what patients would do best, I think patients without atherosclerotic cardiovascular disease would be the patient appropriate for cagrilintide. But I think once you start having your very high risk patient or patients that have cardiovascular disease, it's hard to get rid of that GLP-1 component. But Tricia, I'm sure you're aware of the preclinical data with amylin, which there's a lot of potential benefits there. The decreased metabolic adaptation. By that I mean that the energy expenditure with weight loss doesn't fall down as much and stays up there, which could favor weight loss and weight loss maintenance. It preserves bone. It binds to calcitonin receptors. We used to use calcitonin to treat osteoporosis. And it also it's insulin sensitizing, it's leptin sensitizing. And leptin's involved in reproductive biology, and I'm thinking they should look at kind of hypogonadism and other things like that. I mean, there's a lot of potential benefits of amylin that we need to know more about in terms of how it behaves in human beings.
Yeah, and I think that's the big gap. You see, this is the problem with sometimes how we translate animal study findings to humans, because we'll start first with the metabolic adaptation and energy expenditure, because in the GLP-1 area, GLP-1 increases EE in my studies, but that's not translated to man. So this is where I think that there's a big gap for us to try and also address, actually. Does that amylin's, ability to maintain that energy expenditure translate? Because if it does, that's really, really exciting. And, will add to how we actually choose these drugs, but it's not done. And same with all the bone, etc. And there's a lot of unexplored avenues for the amylin, because there's the amylin, the 3 receptors, endocalcitonin receptors as well. And the problem with the drug development is that some of these drugs they target the weighting on the different receptors are different. So it's another conundrum. But it's exciting.
Okay.
Giovanna, there is another question.
Yes, there is another question in the chat. I'm really excited from all of your explanation, and to go behind the weight loss, to go in deep into the biological meaning of what we see with the weight loss. And Carlo's question was very good, why there is not a summatory effect, and all is fine. But then the question is more clinical. There is a concern about the muscle mass that we can lose with these drugs. So the question exactly asks, are you concerned regarding the loss of muscle mass in this multi-agonist medication? Which agonists pose the greatest risk for this? So it's a more clinical one, but still goes into the biological area.
Okay, so shall I start with this one, Tim?
Yeah, Tricia, you take it.
Okay, so I think with the amylin approach, there's a thinking that there may be a muscle sort of preservation or less muscle loss, but it's not studied yet. A lot of these it's only until recently, I think, with the trial design that people are trying to address, to look at muscle loss, but also function. And I think where we're missing a trick here is that it's the target population, because if I'm giving a weight loss intervention treatment to an elderly person with multi-comorbidity, the likelihood is that they're going to actually struggle more with that muscle loss. When we see weight loss interventions for younger people, they become more active. And it's also brings in the how we approach weight loss therapy, which is why the wraparound care is important. Because if you're on the right diet, you're exercising, I think the risk is low. However, some drugs will target muscle loss more than others. For instance, the glucagon approach therapy. So those combinations, you may need to think about, the risk of muscle loss more than just a GLP-1 approach. Certainly in our clinical practice, I don't see that as much in patients. They report, sort of being happier, more active, and mobile. And bariatric surgery, we've been doing this for many, many years. With weight loss, you always lose fat and muscle, right? But if you're able to take in your protein intake and exercise, you can preserve it. But certainly the more at-risk population, like the elderly, we need to think a little bit more carefully.
So I'm not wrong if I say to my patient, when you get a semaglutide or whatever, right now semaglutide or tirzepatide, when you get this drug and you start losing weight, you can exercise. As cardiologists, exercise is something that I cannot, take out from the healthy behavior of my patients. So I'm right saying you now should exercise because you can exercise.
And the right exercise, right? It's a combination of resistance, exercise, and these things can be graded, which is, I think really important in clinical practice. If we're trying to implement these properly, we should actually put in exercise programs as part of the holistic management of these patients. And diet, obviously.
You had a DEXA sub-study within REDEFINE 1 addressing this very question, assessing the relative reduction in body fat as opposed to lean soft tissue. So can you elaborate on these findings?
Yeah, what we found there, Carlo, was it was similar to what we see with other medications and lifestyle and bariatric surgery. There's about 2/3 of the loss in body weight is due to loss of fat, and about 1/3 lean mass. And these studies do use DEXA to assess lean body mass. But it's important to keep in mind only about half of lean body mass is skeletal muscle. So I think we need more precise measurements of skeletal muscle, maybe MRI, muscle volume. Those studies are ongoing, but we need better definition to see, really determine how much muscle mass we're really losing. And Tricia's right. And whenever, in all of these studies, muscle loss doesn't appear to be a clinical problem by and large. Patients report increased quality of life. On questionnaires, they report increased physical activity and physical function. We do need to pay careful attention to patients with sarcopenia and elderly patients. I agree with that. But we've had all of these interventions in bariatric surgery we've had for 50 years. There's not a problem with weakness. But I'll tell you something I've thought about more is when you look at patients more long term, like in the SELECT study or the Look Ahead study, you're seeing increased falls and fractures. And in the SELECT study, not across the board, but if you do look at a sub-analysis of women and elderly, which I was happy to see was defined as age 75 or above, then you're seeing more falls and fractures. And I think that could reflect a decrease in muscle mass because you need muscle to support joints, as well as a decrease in bone mass. So I think we have to think about that more as a long-term adverse outcome of aggressive weight loss therapy like this.
I see Filippo Crea on the screen. So maybe Filippo, you would like to say something, to ask something, to add something of value, of course.
Well, I'm just connected, because I'm at the airport and I'm supposed to stay behind the scene today. I'd like to listen a bit more to what you're saying, and then I have some comments. But please carry on before I make my comment.
Okay, let's look ahead, Giovanna, and besides the greater scientific insight that Tricia was addressing and the research agenda that she elegantly defined, let's think in terms of what we need from a clinical perspective. Certainly longer-term safety data. And Tima, I was wondering whether REDEFINE patients are being followed up for longer duration than the 72 weeks that they participated in. And the second aspect is outcome trials. Can you tell us something about REDEFINE 3 and what is its design and what kind of question will it address?
Yeah, although there is a follow-up component to REDEFINE 1. I'm not sure of the duration, but these patients will be followed for a longer period of time, off medication, of course. And you're right, there is a trial ongoing, REDEFINE 3, which is a cardiovascular outcome trial. It's targeted to enroll 7,000 patients. So to me, that means they're definitely going for non-inferiority and maybe hoping that's enough to demonstrate superiority. But they will enroll patients at very high risk of cardiovascular disease or with cardiovascular disease. So I was happy to see that being done, that study being done.
But is it compared to placebo or to semaglutide?
I should know that, Carlo, but I don't know that. Maybe some of our other discussants know that. Tricia, do you know?
If I remember, Tricia, Lancet editorial, she was criticizing the fact that a placebo comparison would not tell us what is the contribution of the two components. Was it this your point, Tricia?
Yeah, and I think REDEFINE 1 also shows it, right? It's we had at 68 weeks there were less people on the placebo arm who continued on the trial, and we're now at an era where we have a lot of knowledge on what we're expecting from these GLP-1 plus drugs. So I do think we need to rethink, the trial design in terms of certainly in this category, because is it actually fair to patients to be asking them to go on placebo when we know that there are efficacious drugs out there? I mean, what would be really nice, and I don't know whether the REDEFINE 3 has that in place, is to look at the long-term effects of cagrilintide itself, because we're lacking in that evidence. Well, it's nice to push forward the dual agonist approach. It would also be important to try and understand how each of these drugs work, so that we can actually, it'll help us in the future in terms of how to select treatments for the different patient cohorts.
Talking of this, Tricia, are you aware of any drug development of amylin agonist on their own that is not combined with the GLP-1 agonist?
There's certainly, well, the spin out that we did here, but it's now gone over to Metsera, and so I have very little to do with it. But there was a long-acting amylin, but the idea is also to combine. I think, and there's also amycretin, but again, that's a monoagonist with a GLP-1 and amylin component. I suspect there is other pipeline development. It's a very competitive field, and I think what people are trying to also debate is, which receptors are more important, and do you need also the calcitonin receptors? Lots of unanswered questions. I don't know the answer. I would like to know. And
for cagrilintide, there is a program called Renew studies that are examining cagrilintide as a monoagonist. And as Tricia mentioned, there's a lot of interest in this area. There's many companies developing long-acting amylin agonists, even oral agonists.
yes.
And hopefully some of these companies will do a cardiovascular outcomes trial. The Renew series of trials, I think, is still being thought out. And I'm not sure they have considered a cardiovascular outcome trial at this stage, but hopefully that will happen. So we'll see. But I think those would be really interesting studies to do, and would really advance this concept of mine that, we need a medicine like cagrilintide that could give us close to 15% weight loss and still confer cardiovascular benefits and be well tolerated at the same time.
Okay, there is in the chat another question that I think is very interesting, and is this one. Do you think there is any concern regarding tachyphylaxis with these drugs? We do get some gradual weight regain in the longer term with bariatric surgery, for example, and is also known with other drugs. What do you think about this? Because this is another point.
Yeah. Well, I don't think these drugs were just approved in 2021. So, and tirzepatide in 2023. So we don't have long-term experience, but, with the SELECT study was a 4-year study, and there was no evidence of tachyphylaxis. Step 5 was the 2-year study. So, 2 and maybe 3-year studies of observations haven't really revealed tachyphylaxis. But I don't think we have really long-term data to answer that question.
No, but certainly the data that we've had, 4 years up to 4 years plus, is encouraging. And I think, within that patient cohort, there's probably been like kind of up and down titration of treatment as well, which yeah, I think so. It'll be interesting to get longer term data and to know how we manage this long term. We've not done it, but my understanding is that there is a long term down titration study planned, I think.
I think Eli Lilly with tirzepatide has a study to kind of use maximal doses, 10 to 15 milligrams, bring people down to an equilibrium level of weight loss. and then switch them over to a smaller dose, 5 milligrams, to see if you can retain the weight loss, which I think clinically that's the kind of data we need.
Yeah, no, and that'll be good. And then obviously you've got the other opposite where Novo Nordisk has done the semaglutide up to 7.2 milligrams and showed that you can get that added benefit in terms of weight loss. So yes, so you can go up and you can go down in dose. But I think that reflects real world. And, you know, often we see patients in clinic and they're like, hey, can we go down? And we do actually move down in dose. And then if they start to regain weight, move back up.
My experience too.
Tricia, if I can go back to your interesting Lancet editorial where you comment on amycretin phase 1 studies. One of the 2 studies used the subcutaneous route of administration. The other used the oral route. Now, this is a practical issue, an important clinical question. Is there viability for an oral route of administration of these agents, which obviously impact on tolerability and perhaps sustainability of?
I think so, because we all see patients, you know, who don't, you know, if you say take a tablet versus injection, they would prefer that approach. The oral route for normally peptide delivery can be difficult, but you know, there's also now small molecule approaches. So I think we have to watch its space. Obviously, you've also got orforglipron, which is a small molecule and achieving, you know, more than 10% weight loss. And it's an exciting option. It's just from not having. I remember doing, you know, clinics where we had no options, no effective treatment apart from, you know, orlistat for patients. Now we have lots of options. Although patient access is to treatments is a different question, but you know, at least we now have the choice. And yeah, I think oral is very exciting. Even with the semaglutide Rybelsus, they've recently improved their formulation, so they're giving smaller doses, etc. So it's you know, we're making a lot of progress.
Well, the data we have to date, though, Tricia, show that the oral preparations have equal or even perhaps less efficacy than the injectable counterpart, and still have the same side effects. So I think you're right. It boils down to patient preference, and it's good to have both of those arrows in our quiver, if you will, because we really need to aim better for long-term adherence to patients taking these drugs.
Agree, and not all patients, as you mentioned earlier, Tim, needs to have that 20% weight loss, right? We achieve that 10% weight loss. It's exciting. I like also the option of oral in terms of safety, because the washout period is less, and certainly in the one area that really has been neglected is in women's health and fertility, in terms of all these trials that's been done. Okay, because the preclinical studies have shown that the drugs lead to malformations, fetal, you know, development. There's been issues. It's unclear if it's a direct or weight loss effect. But we've not studied that. It's very difficult to study. It's you know, I think drug companies won't do those studies because, you know, that there's a risk there. But if you've got oral treatment, it's actually an option because you've got a faster washout. We're all seeing women. I see a lot of women who end up, you know, getting the drugs privately, not on contraception, getting pregnant, coming to our clinic worried. And certainly with tirzepatide, you need at least a 1-month washout. Semaglutide 2 months. So the oral option does offer some advantage in that cohort of patients. Not fully evidence-based, but, you know, certainly from a pragmatic approach.
Great. So we are also defining, going ahead with the dialogue, we are also defining the subset of patients that can benefit more of one type of treatment than another one, putting all together what we have learned this afternoon, and maybe listening to the dialogue when we'll be online, we will create a more clear picture, because my question was the first one and still is the patient selection. So really, I appreciate.
We have Professor Crea who wants to ask a question.
Well, yes. Question. You know, in Italy, we have a proverb which sounds more or less, if you eat good things, paradoxically, the appetite increases. Now, the story of these drugs has been extremely successful, so I'm sure that the appetite in their utilization keeps increasing. What do you see in your crystal ball? Started as anti-diabetic, then obesity, then cardiovascular protection, a wonderful trial showing protection also in patients with peripheral artery disease. What do you see in the crystal ball? Do you think that this can be extended also to other diseases? There's been a signal, for instance, for dementia. And what about liver steatosis or even chronic kidney disease? The story is so successful. In fact, what do you see in your crystal ball in the foreseeable future for these drugs? Both of you. Ladies first. Okay. Ladies first.
So I think as long as we continue to push forward research, basic research into this area, we will actually move to an area where we will be selecting patients for the different benefits, whether it's going to be the weight loss primary target, but weight loss, I think, will benefit everything anyway, to some of the weight loss independent mechanisms, because these drugs, there's signals that things like psoriasis, GLP-1s improve. So there's an anti-inflammatory component, but studying those things are very difficult. But, I think we need to continue to interrogate how they work systemically in the different disease. And certainly the way I would prescribe and choose my drugs will be based on the comorbidities and what are the evidence that I have to hand in terms of the long-term safety of the drugs.
Exactly, Tricia. So, these as I mentioned before, I view these medications as cardiometabolic disease medications because they treat and prevent so many aspects of this in this nexus of diseases, as well as biomechanical complications like obstructive sleep apnea and osteoarthritis. But in terms of the future, I'd like to see a trial looking at secondary prevention of breast cancer, for example, or in a perimenopausal study as well, where there's a state of accelerated bone loss. That's where I'd like to see a long-acting amylin study being done. And the GLP-1, maybe this can help with vasomotor instability as well, and with hot flashes and whatnot in menopausal women. So there's areas like that, I think, and then weight gain induced by antipsychotic medications. And you've mentioned the anti-inflammatory. I know people from NIH called me asking for advice on a study they're thinking about in long COVID to see if GLP-1 receptor agonist can improve long COVID symptoms. So it's kind of exciting. There was a report recently, it improved rheumatoid arthritis. So there is definitely an anti-inflammatory action here that can be examined and evaluated for other diseases.
Including FF, where microvascular inflammation plays an important role.
Right. Yeah. And I thought it was interesting. I think Giovanna mentioned that for HFpEF, we had SGLT2 inhibitors, but not much else. Of course, now we have the GLP-1 receptor agonist. And in the SELECT study, when you looked at people that were already on SGLT2 inhibitors, the addition of the semaglutide led to greater benefits, great improved outcomes even further. So these agents can be combined in these patients, hopefully for better outcomes.
So in summary, the Italian proverb is correct. If you eat good things, the appetite increases.
I like that.
Okay.
What if it's a Mediterranean diet, though? That's, there's advantages there.
Actually, Filippo, you had done my last question, because my last question was about ambition. And the ambition was asked by our editor-in-chief. So from my point, I really enjoyed this dialogue. If there is other questions that can come from Carlo, I see Massimo Volpe. Maybe Massimo, you would like to ask something more. Massimo is an editor of the European Heart Journal too, and is in the staff with Carlo and me in the staff of the weekly journal Scan. Massimo.
Yes,
No, you can speak. Yeah.
Basically, I enjoyed the dialogue until there was an electric problem in the house, and I lost 5 minutes of discussion. But as far as I heard, it's just great, and thank you very much for being here today.
Thank you, Massimo. Yeah. Giovanna, your final words to conclude the dialogue?
To conclude the dialogue, I think that today we have done a good job in putting into context an important part of treatment for patients with cardiometabolic disease. And we have also had a look on the future and on possibilities that are increasing and increasing. We have also done the point about patient selection. And I think that there will be few spaces for different type of drugs. I see this drug will, go to improve the outcome of really patients with a lot of comorbidities that at the end will become the holistic treatment of people with cardiometabolic diseases. So I enjoyed very much all the discussion, especially the biological point of view, because, I'm really fan of biology that is behind the things, behind the disease, behind the medication. So thank you very much to all of you. And we have also a lot of audience that are listening us, and I hope they enjoyed as I did.
Well, also from my side, thank you very much for this wonderful dialogue. Giovanna is right. We will have thousands of views in X and YouTube. These dialogues have become very, very popular. So thank you very much. It's been really enjoyable. This hour has been extremely useful for all of us. So thank you for your time. And let me announce next dialogue. The next dialogue will be, as usual, on the last Thursday of November at 5 o'clock Central European Time. And the next dialogue will be with Professor Junbo Ge from Shanghai. We move from US to China. It will open a window on Chinese cardiology, which is evolving so quickly. Our journal is global, and it is a great pleasure to be part of this very, very interesting global, worldwide community. Thank you again, Timothy and Tricia, and I hope meeting you soon in one of the interesting meetings around the world. Thank you. Thank you very much.
Thank you.
Thank you.
Thank you all.